Today we've talked about design, implementation, how to actually deliver change at scale. This last session is going to be about the future. So what's next for digital healthcare? So yes, we're only waiting. Perfect. So before I introduce the panel, I want to say a big thanks to PA Consulting for actually making this session possible. Yeah, there we go. Excellent. So yeah, I am joined by Jonathan Pearson. Jonathan is head of healthcare at PA Consulting Group, where he works with private and public sector organizations in projects related to digital transformation, productivity, and the use of advanced analytics. Jonathan, if you want to take the stage.
Yeah. Thank you, Claudia. Good afternoon. Quite a big topic for 7 minutes, so I'll go quickly. When I was a young hospital manager, I worked in a 1,000-bed teaching hospital in the Midlands. And I did some night shifts with the night managers to find out how the hospital worked at night. And it was effectively run by 3 veteran nurses. And one night at 2 a.m. in the morning, over a cup of tea, I said to them, "What was the worst night you've ever had?" Without batting an eyelid, they said, "That was the night we had the power cut. And the backup generator failed, and the backup generator failed, and we knew we had 30 minutes of battery on some of the ventilators in intensive care, probably 60 minutes on some of the other equipment, and fundamentally, we would not have enough people in the hospital to keep everyone alive if the power did not come on." Now, I share that as a metaphor. A hospital without electricity is not sustainable for very long. And the same is true of our health system and of many other health systems. Healthcare provision in our country is simply not sustainable. In 1970, which you can tell by looking at me was about when I was born, we spent as a country 4% of our GDP on public and private healthcare. By 2016, that had gone up to 9.7% of our GDP being spent on public and private healthcare. That's roughly a growth of 2% per annum over that period. And we've got some clever economists at PA, and if you extrapolate that out, by the year 2100, we'll be spending 56% of our GDP on healthcare. And global is in my talk title. So for France, it's 45% by the year 2100. Sweden, 42%. The Kingdom of Saudi Arabia, by this time, will be spending 76% of their GDP on healthcare, and our friends in America a whopping 91%. Now, one can argue with the analysis, but the point simply is, at current trends, healthcare is not sustainable. So clearly, we need to do something different. Clearly, we need to transform healthcare. But healthcare productivity, we've had a little bit about this, is not increasing fast enough. In the US, productivity has actually declined over this period. In the UK, you can see in the graph behind me, over the last 20 years, health and residential care productivity has increased by just 0.9%. I think Simon Stevens quoted 3% maybe for the last couple of years, so it might be edging better. But taking a couple of decades of data, it's 0.9, less than half of some of the other sectors. And you can see social care productivity has actually gone down over these 2 decades. And just to put that into context, the NHS needs to be delivering productivity improvements of about 5% per annum in order to meet this productivity and sustainability challenge. Just to put that into maybe what that means for people, Health Education England report that if we don't reduce demand for healthcare, if we don't increase productivity for healthcare, we will be needing roughly 190,000 additional staff by the year 2027. And that is double the number of staff that they estimate will actually be available to be hired. So, how do we accelerate the increase in productivity? How do we accelerate this productivity improvement? I'm a keen cyclist for the people that know me, and we effectively need to do two things, and we've heard both of these this morning, but they are like the pedals of a bicycle. You need to keep them in unison. And the two things are technology on the one hand, and then embedding it into people's behavior and organizational culture in the other hand, and keeping the two in unison together. So it isn't all doom and gloom. We can make a difference. And just taking those two in turn for a moment, health technology can increase productivity. And the big trend, in our view, across a lot of these technologies is the increase of precision with which we can do things. And precision enables increases in efficiency, productivity, and the quality of care. So just a few examples. In population health, the aggregation of health data, social data, environmental data, all sorts of other data that we've been talking about, that enables us to do a number of things. For example, target interventions at the people we think are at risk. So as an example, we've developed an analytic that predicts for children with asthma which ones are likely to go into hospital. So an intervention can be made in primary care to mitigate that happening. In care delivery, I still think we're just starting on the digitalization of care providers, but that digitalization of providers will enable a whole number of things, including the real-time predictive management of patients through the system, optimizing key assets like theatres, intensive care, and diagnostics, and managing patients predictively along care pathways. That digitalization of providers will lead into the digitalization of the patient experience, and we've had a lot said on that this morning, and clearly care won't just move from hospitals to the community or move from hospitals to care anywhere, become a mobile experience, and a lot of what is done in outpatient rooms and so forth will go through online and telephone channels. But it's not just the patient-facing stuff. Robotics will automate a lot of the back office. We've implemented a sort of Uber-type app for temporary staff, which has yielded a lot of efficiency savings for a number of NHS trusts. So the back office can be improved as well. So just a few examples. Technology can improve productivity, but it needs to be successfully implemented to get to the benefit. And to do that, it needs to be seen as a change program. This is not just a software install. So as a change program, the three key questions of change need to be answered for all the stakeholders. Why change? What's in it for me? And how will I cope? And I think the example in the first session of some of the people that are struggling with the technology is key to that third question. They need to be answered for the technology to be used. And then secondly, as a change program, it needs to be driven by the benefit. So what is the benefit for whether it's the population, for the user, the human, the taxpayer, or the organization? What is the benefit we're driving from this technology? And designing and driving the change program accordingly. Not, we've got some cool technology, how do we deploy it, how do we find a use case for it? So as I'm getting flashcards to tell me that I need to stop, let me take you back to that metaphor of the hospital at night. And thankfully, in that real example, the power did come on just in time before some of the batteries ran out. But as a metaphor, in the same way that a hospital works so much better with electricity, so we can improve productivity so much better with technology, and technology can be a positive force for a bright human future, but it has to be embedded into human behavior change and organizational culture. Thank you.
Thank you very much, Jonathan, for that very insightful presentation on productivity and implementation as a change program. Very interesting. Next up is Lydia Nichols. So Lydia is program manager at independent think tank Everyone, where she looks at innovation and policy within health and social care.
Hi, so I'll be talking to you about imagining a better care system for a fairer future. Now, I do feel a little that despite the time limit, I need to justify in some ways taking the time to imagine when we're facing so many real and present crises. But I can assure you that I spent years working as a developer. I've spent years working in hospitals, and I spent about 5 years in Nesta, split between their futures team and health labs. So I am allowed to talk about imagining. Trust me, I've justified it. Okay, so why did I want to talk about futures in this particular project? Basically because we know that there's a problem now. Right? In social care, we know that there is this enormous gap in productivity, in funding, in workforce, and we know that all of these things are going to get worse. When I got the opportunity to do a short research project, I didn't think there was much point in my using my own resources to quantify, again, exactly how much suffering is going on in the, and how much unmet need is occurring in the country and around the world. So instead, I wanted to take a futures-orientated approach. This involved running workshops up and down the country, and also running mini versions of the workshop, visiting support groups and doing site visits and people that organize social care and deliver social care and support systems. I'm dwelling on this because I think it's something that more people that are trying to pursue radical change and try and improve their systems should consider. So this workshop allowed us to support people to share their own experiences and stories, to then explore and debate new possibilities. We put up all sorts of prompts about radical policies, like, say, in Shanghai, children are legally obligated, they are legally responsible for their parents' spiritual development. So if you're not looking after your parents, you can be sued by your parents and by the government. And then or robots in care homes, or AI, or fall detection, or all sorts of things like that. We got them to talk about that. And then we supported them to tell really hopeful, positive stories about the future that managed to capture what people really wanted for their families, for themselves, for their communities. And then that enabled us to work with people who have often felt quite ground down by the system to imagine, to plan a very deliberate path from here to there, and thus come up with policy proposals that were not just fiddling around the edges, but were really quite radical and forceful, and sometimes surprised and shocked even me. So this is how I did it. There is a really nice book, online book that I really recommend that people look at. The Government Office of Science down the road has created this futures toolkit, or a foresight toolkit. And one of the things is, I've been talking and lecturing on this stuff for years, but what's nice is that it's very scientific and it's verified by the government with a big tick. So you can feel that you can give this to all of your management and they'll believe it's a real thing. So then, obviously, I then sort of put that on a slide, working with easy read consultants, because we had people with physical and learning disabilities, autism, dementia, and so on. And then we got them all to have these wonderful debates about exactly how they wanted tech and AI and culture and communities to connect together. So that was the rapid run through the method. What did we find? Oh no, that's the method as well. We did lots of things. There, what did we find? Sorry, yes. So cost is not actually the most complicated problem. We all know that cost and funding, and like we've heard about the productivity shortfall, are terrible challenges, but I believe that this is tightly interlinked with complex cultural challenges that we have as a society. Obviously, I'm going to come up with that answer because I'm an anthropologist, and thus I want you all to hire more anthropologists. But trust me, there is truth to this. So I talked a lot to people in this and in previous work about automation in the healthcare service, and I really think, and I've been all over the world to talk to people about how. Oh goodness, I'm like halfway through. So we hear this story. Automation will take away the menial tasks and free humans to focus on creative and meaningful work. Now, there's a lot of problems in that statement. Firstly, if AI or if robots take over routine tasks, routine is how we build relationships. Routine is how we build trust, is how we build homes. Routine is caretaking. It is how you develop love, trust, support, and family. And also, what is menial is different for many other people. The sorts of tasks that I've seen people deliver, putting on someone's socks, wiping someone's bottom is an incredibly important task. If it is done wrong, people can get deadly infections. If that is not done in a way that allows people to have dignity, to have the kinds of privacy or at least the sort of support that they need, you can damage someone in ways that they cannot be fixed. But this is work that we sneer at. And so this is something that I want to tell all futurists, as well as all people working in health and social care. We've talked about how automation will allow people to do people's work. I talk to people about the future all the time. And the fact is, we don't know what's going to happen in the future, except that we will all get older, except the ones that are hit by a bus. We will all get older. Children will still need to be raised. Older people will still statistically accumulate more disabilities and chronic health problems. In fact, we all will, and we will live longer with those. We will need to look after one another. I've been asked on stage, what will we do when there is no more work? There will always be work until the last person has the housing, the social connections, the love that they need to thrive, then there will always be more work. We just choose not to value that work. In terms of policy proposals, what has happened is, so more tech on the front line, more tech in people's home, more fall detections, more data being collected. That actually means more complex and creative decisions from frontline staff. I see over and over again hospitals and care homes and providers, sorry, I am abusing the time limit in all sorts of ways. They think that by including more technology, they can cut workforce, or they can cut training for workforce, because the machine will do the thinking. In fact, plugging those things together and making them work on the front line, taking on the complexity that is always spat out by a system that gets more streamlined, that gets more data intensive, that requires complex decision making. But over the last few decades, we have absolutely decimated the decision-making skills of health and social care workers on the front line. We have about half as many district nurses now, or we're funding half as many of them as something like they've dropped by 51%, and I cannot remember in what context that stat comes. But we are decimating that. We have got appalling training and registration systems for care and support workers, and we are not supporting that workforce to become more skilled, to be more productive, to actually do anything with the technology and the data we're collecting. I'll zoom through this. Yes, but this is what we're actually seeing. Instead of people who are empowered to use data to improve decision-making, to improve people's experience and outcomes, instead it's being used to spy on people and make them work like machines, like robots. So essentially they are the hands, and they are reduced to performing tick box tasks in a way that stores up complex problems for the long term. I'll zoom through this as well. This is a story of the Boeing something that crashed recently, and the finding at the outcome of the inquest was that a fractured decision-making process had meant that different design elements of the team were not able to work out what the underlying cause of what the impact of certain changes to the code and the sensory system of the aircraft would be. Now, this looks a lot like most people's experience of health and social care. Talking to a dozen different specialists, none of whom have the capacity or the time to talk to one another, and no one who owns the problem, no one who can support the individual and work out underlying causes. So I'll end on this quote, which is that we need some sort of metric to measure how if people are being loved or happy as a way of demonstrating that they are cheaper. They are. If people have a comorbid mental health condition with their physical health condition, their total healthcare costs go up about 45%. Now, because people with multiple long-term conditions are the people who end up using the NHS the most, that, by some estimates, accounts for about 1 in 8 pounds spent in the NHS. So If we can own these problems, if we can talk to people as whole people, if we can connect the challenges that they're facing in their society, in their community, and support people if we can aim for some outcomes, which genuinely, as a whole NHS and a whole social care service, we don't have an agreed set of outcomes to aim for, then we're not just going to make people's lives happier and reduce suffering. We could genuinely be solving a lot of our staffing and funding cost problems as well. Thank you.
Thank you very much, Lydia. So now we're going to go on to our last talk. I'm very happy to introduce Manish Juneja. Manish is a digital healthcare futurist who explores how emerging technologies can help us create a better, happier world.
So I want to talk to you today about health beyond healthcare. We've heard a lot today about the NHS and healthcare, and many of us have been led to believe that healthcare equals health. That's all we need for good health. However, this is a really interesting graphic from the US, from Kaiser Family Foundation. And when you look at actually the social determinants of health, and you think of things like income, you think of things like education, housing, parks, transport, all of these different determinants of health that we don't always think about. It's not front of mind. And, you know, the contribution of healthcare itself is actually not that big to our health. And if you look there as well, I want you to focus on discrimination, whether it's racism, whether it's bias and discrimination because of your gender, or because you're disabled, or because of your sexuality. These are all impacting our health. And this is a really interesting graphic, again from the US, where they're trying to estimate the contribution to our health of these different factors. Look at healthcare, i.e. the NHS, 10%, behavior change, 40%, social environmental factors. So think about all those daily choices we're making. Sometimes we don't have a choice. We're forced to make a choice because we don't have enough money in terms of the food that we have to eat, for example. But think about what needs to change if we really, really want to make an impact on health. This is an interesting report by the Special Rapporteur from the UN, Philip Alston, and interesting to note that in this hall, this is where the first meeting of the UN General Assembly happened in 1946. Now, he visited the UK and he did this report on poverty and human rights, and he found actually 14 million, he estimated, live in poverty in this country. And then the austerity policies have impacted people, their health, their well-being, and that actually future forecasts, children are going to be deeply affected in this country by poverty, again, as a determinant of health. Now, what's the reaction from Philip Hammond, the Chancellor in the UK? Well, he'd say, I don't believe you, UN General Assembly, you're talking nonsense. I don't believe that there are millions living in poverty in this country. So think about that disconnect between what others see and what government and policymakers see. This is an interesting one here in terms of social care, as Lydia talked about. I talked the other day to a friend of mine, 97-year-old father-in-law, trying to choose a care home for him. He described the experience as traumatic for himself and for his father-in-law, right? So this is social care. And if you look at, there was supposed to be a green paper published by the government describing what they're going to do on policy. That still hasn't been published. We don't even know if it ever will be published. This is a huge, huge challenge when we're thinking about health, right? Especially as we have an aging population. Also, there's been suggestions by some people in NHS England, in terms of advisors, well, you know what, old people are lonely, let's just give them a smart speaker to keep them company, remind them to take their medications. Is that really, when we get old, is that really how we want to live our lives? Are we not able to tackle the causes of why people are feeling lonely, what's happening in the fabric of our society? And then here, even the Care Quality Commission did a survey last year, and they found that choosing a care home for yourself or a loved one is one of the most stressful life events. Right up there in terms of stress, again, determinants of health. Right? We need to be tackling this. We need to have a national conversation about social care and put it on equal footing as the NHS. Then, if you look at public health and prevention, so everyone is saying we need to move to prevent disease, right? It's the correct strategy for a healthier future for this country. However, Public health has been underfunded. Public health and prevention is not at front of mind, not just for policymakers, but also for the public. This Ipsos Mori poll last year, when they asked what should the government be funding when it comes to health and care, what are the priorities? Look at it, urgent care and ambulance is right at the top as a priority in terms of funding. Public health and prevention right at the bottom. There needs to be, as Lydia was talking about, a cultural shift in how we view health. What's our approach to health? Then, air pollution. Today is World Environment Day, so this recent study showed that air pollution impacts every organ in our body. And this was a recent white paper from the British Safety Council. So think of those workers working outside, even those people delivering your meals on their bicycles, they're being impacted by bad air quality here in London and across the UK. And even Matt Hancock has announced that he's going to launch a study looking at the impact of air quality on our health. I've got a personal pollution monitor. I've tested the air quality in this room. I'm afraid to report that it's really high pollution levels in here, nitrogen dioxide. So sitting in this room today is actually harming your health. However, it's not all doom and gloom when it comes to technology. So when it comes to health beyond healthcare, this is Roland. He's living with Crohn's disease. He's in the Netherlands. And what he decided was the system wasn't responding to his needs in terms of helping him cope with his Crohn's disease in between visits to the specialist in the Netherlands. So he's creating a chatbot for people living with Crohn's disease. He's now got some more funding. He's doing this all on his own, as in he's a patient who's spearheading this innovation. So it's not necessarily coming from the system itself. Then, also chatbots, they're not always done well, so I've tried some out. So this is one called Zini. It's just a random app that you can download as a chatbot. It claims to be a virtual assistant helping you with your health. Look at when you're talking to it about cutting your wrists and you're bleeding, and look how it responds, right? So this is the danger as well of going down this technology route. The third one is a Replica, which is a general sort of mood tracking friend virtual assistant. And you talk to that one, ask questions about immigration and Brexit, and look at it talking about, I'm saying, should Britain go ahead with Brexit? Yes, I'd like to. Why? I want to help the environment. Right? So think about, again, what we're being exposed to in the two sides of the same coin when it comes to technology. Again, when it comes to health beyond healthcare, you've got power companies in Japan helping to spot when people are dying, because old people are dying, they're living alone in Japan. Sometimes their deaths are going unnoticed for months, right? So they're monitoring electricity usage to see when somebody living alone, their electricity usage changes, right? And so being able to spot somebody has passed away in their home. This is an interesting video on Mercedes that I've tried, and it's showing you how these car companies may soon be knowing about our health and being able to impact our health. So here we are talking to our car. How soon before we say to it, I'm sad or whatever, it detects automatically in our voice that we are feeling sad, and then it says, hey, do you want to stop and have meditation or even a digital therapy, right? So again, think about where we're heading with technology. Then this is a really profound shift. One of the most amazing things I've read about in the last few months. This is 11-month-old Annabelle in Devon, and with her older brother Lucas. So she was about to say her first word, and her mother and father were going, okay, we're so excited. Is she going to say mummy or daddy, right? What does she say? She says Alexa. Her first word ever is because her older brother, she's been watching use Amazon's Alexa, that smart speaker. So think about it. The patients of tomorrow, is she going to be more comfortable trusting a machine, an AI, right, an assistant like that, rather than a human healthcare professional, or even members of her own family, because their primary relationship since birth is basically these machines and this AI around them. I also want to talk about Dame Sally Davis. She wrote this report last year. It was published, 280 pages about the health of the nation in 2040. Now, lots of things here, but they're talking as well about cross-sector thinking, expanding our view of health. All good things, intelligent prevention and prediction. All very good, right? Very useful read. However, think about this scenario that you could be today. You're eating crisps with your friends, playing Jenga in the pub or the office. Maybe you're eating too many crisps, or you're having too many beers, for example. In the report, I'm not going to read all of this, but this vision of the future is you have an electronic health engine and there's the digital nudges and it's saying, hey, you shouldn't eat those crisps because you've got high blood pressure, right? Or for example, your fridge in this scenario is linked to the government and the government is actually, the AI is adjusting your food reordering process based upon what the national dietary guidelines for your family are. So I just think, again, our freedom to choose, behavior change. Is this the only way to make the NHS sustainable, to get us healthy, to make us comply with the right behaviors? And then, again, we've been talking for a number of years, we've had government reports about prevention and healthy, and how do we make a healthy future. This report just came out yesterday, the one on the right, talking about a health audit of all government policies. However, we're still talking about it. In New Zealand, they said, let's just design a budget where every government policy is designed around well-being metrics, not about economic growth. So I think I want to close on the fact that I believe we are worshipping false gods. I think the adulation we've got for the NHS is taking us down the wrong road, and we're not even considering the changes and the reforms that are needed. We have this very restricted view on health, that it's through the healthcare system, that only prevention, etc., can be delivered through the NHS. We're not thinking enough about public health and social care. Also, medicalisation of life. If you're lonely, why should you visit your GP? Why aren't we examining why people are lonely in the first place? How are we living? How are we working? How are we playing in society? Short-term targets. I meet so many people in the NHS and they say to me, Manish, I'm just being these short-term targets, it's about performance and outputs and process. It's not actually about improving health. And I think, again, we need to move away from these short-term targets and think about what does health mean to us wherever we work in the system. And also about data and technology. So I think, again, AI, etc., can do great things for people's health, but also we are almost viewing it now as a silver bullet. We don't need to do anything else. We just need to deploy a bit of AI and collect a bit of data, share a bit of data, and that's all we need to do. But we don't. We need to do so much more. Things like poverty, discrimination, right? Housing, transport, air quality. So finally, I know I'm a bit over time, but I want to actually ask you to reflect upon all of this, upon your view of health and what it actually means, and to really think, what is it going to take for you living in your communities to make them healthier? What do your individual communities need when it comes to health? And what should policymakers do to actually help us lead to a healthier future? Thank you.
Thank you very much, Manish, for that very thought-provoking presentation. We're going to jump straight into questions. Please raise your hand. We're going to follow the same ground rules laid out by Maxine. So yes, if you have any questions for the panel. No? Okay, I'm gonna kick off with, no one? No, I'm going to kick off with something. So you all seem to agree that one of the greatest challenges in terms of realizing the future of digital health care is actually embedding change. And there's a lot of problems in terms of cultural change and lots of things that we need to pay attention to. Can you tell us about examples that you've seen of that happening successfully?
So, I mean, as I was saying in the talk, I think it works best when you start with the benefit. So, I mean, this is what we do for our living, is implement stuff to get a benefit. So, just one very simple example, which is around efficiency. Big teaching trust, couldn't get enough patients to his theatres, didn't have clearly enough money to build more theatres, couldn't employ more staff. So how do they get more patients through theatres? Some relatively simple analytics to improve their scheduling and patient flow through theatres, embedded with the schedulers and the clinicians in terms of how they behaved. Within 4 months, they were seeing 500 more patients per annum through those theatres. They reduced early finishes, so they're using the time better. They reduced late start, so the staff could get home better. And within 4 months, the return on investment on our fees was over 3 times. So really simple. It wasn't highfalutin technology, but it's about embedding it to deliver a benefit.
I'd probably bring it back to an example that quite a lot of people here will be familiar with, which is, say, the Buurtzorg model that we're seeing in the Netherlands, in which, to bring it back to the kinds of issues I was raising, there is a focus on nurses being part of the community, being empowered to make decisions, to develop relationships with patients and with patients' families, and thus to improve outcomes for the whole community. In those kind of cases, and we are seeing some great examples of people trying that in the UK, and this is that place where policy and regulation and culture and targets all interconnect complicatedly. So there's well-being circles up. Like, I'm trying to remember exactly where that is, and someone can possibly point out to me, but a great organization that are trying to do a similar thing with care professionals in the UK. They say that while outcomes are looking good, the problem that they have is that, say, the CQC's reporting frameworks, and I've talked to the CQC and they hope to change some of this, rely on an idea of a hierarchy of decision making that means that it's actually very hard to meet your targets or to fill in the forms and meet your legal requirements, even if you are getting the outcomes, if you can't point at exactly how the decision-making structure worked because you have been empowering people on the ground. And similarly, Equal Care Co-op, which is officially launching in just a week or so, have been trying to embed similar principles where carers and clients and care coordinators all own part of the business, and so they can all be part of that decision-making in the community and all have real power. Again, similarly, while the model has real hope and they're trying to push this radical change, it's hard to do that without the support from the top of regulators. So I see this as a place where we need to support people who are, as you say, focusing on the benefit, focusing on the grassroots and what they want and what they need and driving change from there, but then that needs to be supported from the top or it gets crushed.
So I've got a quick example of the shift that's already happening, and I've been part of that. How many people have actually downloaded the new NHS app and actually viewed their medical records on their phone? A couple of you, right? Now, actually, what's really fascinating is I had a knee problem, and I went to my GP, and the practice nurse saw me and says, right, you need to go back to urgent care if things don't improve. So I went into urgent care at the hospital the next day, and when I was in the room with the nurse, and the nurse was saying, well, why did the practice nurse send you? I don't understand, right? And I said, I logged into the NHS app, pulled out my medical records, and from the day before, the records were in there showing the clinical coding from the practice nurse that entered on the computer, showed it to the nurse in urgent care, and she was like, wow, like that's so organized. But for me, there's a profound change because for the first time ever, I was able to access my medical record, but in that particular situation, help to direct my care and make it a higher quality experience and hopefully speed up and make it more efficient. But the problem is, though, I fear that if patients are able to do this, for example, through the NHS app, it might mean that there's less pressure and incentive to make records interoperable and solve that problem because, well, you know what, patients are doing it themselves by being the glue in the network. So again, like I said, it's two sides of the same coin.
Excellent. Anyone from the audience who has a question for? Yeah, there's one there.
Hi there. Sorry, I am going to ask a very broad question just because there is some space here, particularly to Manish. I apologize if I'm not pronouncing that correctly. So you spoke about healthcare, the future of healthcare, and all of the. To me, what I was taking from that is these factors and our understanding is going to kind of pervade our entire life and should, and I agree with you. But at the same time, that's not what I see is happening. What I see is almost in the sense that this is a very kind of qualitative view of care and an integrated society that has like a total claim to all the regions of our lives. There's kind of an economic and health economic, which is also trying to kind of pervade all of these different areas as well. To me, these seem at odds. You have this kind of health economic force which is trying to measure and quantify, and the things that you're prescribing. So I'd love for you to kind of expand if you have any thoughts on that.
So what's the actual specific question, though, with regard to you want me to answer?
Do you think that this future that you would like to come about, do you think that it's in any way damaged by the trend that we have of economics taking over health and health economic measures and the quantification?
Absolutely, because one of the things, if you think about the electronic medical record and whatever gets captured, right, when the GP or person in the hospital asks you about something, whatever they're recording, when I was thinking back to somebody who was complaining and they were living with a number of chronic diseases, but they weren't sleeping very well. The actual root cause of their insomnia was the loud neighbors playing drum and bass right at 3 o'clock in the morning. However, when they went to the GP and the GP was offering them a short-term solution of a sleeping pill, right? But because there's no space in that electronic medical record for the GP to even record patient has noisy neighbors, for example, because that would flag up a referral to the council to say you need to send the noise abatement team to sort the noisy neighbors out, right? So part of it is also going back to the economics and this data-driven care, that how are we actually measuring health and how are we actually asking people in society what health means to you? Does that make sense?
Any other? Yes, back there. Gentlemen, yes.
I wasn't going to ask a question, but I thought that was quite an interesting comment you just made about health economics. I think our finite resources in government, not just the NHS. Economics is a study of scarcity, and through health economics we have that comparability between money that is spent, whether it's in social care, whether it's on a NHS budget. So to make sure that there's an equality there of how each pound is spent, what metric do you think should be used so that you can get the greatest value from each pound spent from the government in all areas, whether it's NHS or the wider determinants of healthcare?
Was that directed to me or the panel?
Yeah, it was directed to anyone, because I
I'm
think
going
it'd
to
be
let Lydia
fascinating
and Jonathan.
Well, I mean, as I kind of put up there, someone said we need some sort of metric to measure happiness or being loved. I'm in two minds about this, because if you start to measure well-being, if you start to metricize love and trust and relationships, that begins to be something that will necessarily get warped by becoming a target. But this is why I believe that in the longer term, we need firstly to have, and I'm hoping to release a short report on this in a couple of weeks. We need investment in linking health and social care data and other local government services so that we can get a picture of total health and care costs for communities as much as for individuals. Because at the moment there is absolutely no way for us to see, when you make a cut, where the strain is emerging. I mean, at the moment I sort of see this as one of those kind of blankets where if you pop down on one area, obviously like maybe a bigger balloon pops up somewhere else. And at the moment, because we don't have any way to get that kind of picture, local governments, providers, and CCGs are all incentivized to do short-term fixes that hit their current spending cut targets and have no perception of the long-term harm that's being done. So we need that urgently, although it's a long-term project, we need to be investing in it yesterday. But alongside that, we need to have and this with my data anthropologist hat on, we need to have a reconsideration of what metrics are and what they do. Data is something that people use to supplement their decision-making process, okay? Like AI as well is just a way to manage large amounts of data, to show patterns to people to understand. It can't make decisions on its own, really. When you trust it to make decisions completely on its own, you end up with very strange results, which get further and further disconnected from the real world. So we need to have a connection between data and anthropological or qualitative work in the longer term. So people can reflect on this metric and say, well, that well-being score now doesn't reflect what I really want from life. So yes, a well-being metric that is continually revisited both at a local scale and at a national scale. And that is up for debate and for challenge, so that we can continually keep rediscussing what a good life looks like and what that means. So yeah, linked data and breaking data at the same time.
Thank you. I should say, as well as my role at PA, I'm also the independent chair of a health system. So with that hat on, what is curious is we don't have a health outcomes framework to work to. So the targets we are managed to are all process targets about waiting times or so forth, or input measures. So we've developed our own health outcome framework locally, but that's an odd thing that there's not more of a national steer on that. Two challenges with that. One challenge is there are actually tons of metrics, life expectancy, infant mortality. We've got hundreds of them. Simon Stevens mentioned survival cancer rates earlier. So there's not a lack of metrics. It's about which ones you want to pick on. So the second challenge for us locally is how do we enter into a meaningful conversation with our population about which ones to pick on and not just the people that always turn up. And then pick on a few, and by a few I mean about 15 or less, because that's how we get focus, and crucially line up all the government agencies, so not just health, but education, local authority, and that's really hard because it's fundamentally about power and who's in control and who has the say. One way we've got into this is not to look at diseases, but actually to look at life stage. So we think the first 1,000 years of life and the last 100 days of life are two places we can do a lot better with the money we've given to get a health outcome in particular places where budgets are fragmented and there's lots of service, but it's not necessarily integrated.
I think we have time for one more question. That one there.
Harry Longman. It seems to me, actually, there's a lot of sense being spoken from the platform today about what AI can do. But the question running through this is, what are computers good at and what are humans good at? So a lot of sense from the platform. I see two huge wastes at the moment in the NHS. And one is trying to use computers for what humans do really well. And the second is failing to use computers for what they do well, the boring stuff, the connections, the messaging, the calculations, the searches, where humans are being bored to tears and we say we haven't got enough resources. Well, you know, computers can do that. But all of the attention is being focused on airy-fairy AI, which ain't going to happen. Now, please, panel, how are you going to change that?
I just want to respond and say, so generally, it's not just even the AI piece, Harry. It's just all of this digital stuff that's happening in healthcare, not even in healthcare, generally in every sector, is that what I find is at the moment is there's a lot of digital veneer. So you have a lot of crappy processes that are being digitized, and people are saying, this is great, we partner with a startup or a big tech company, we've done this. And actually, no one's paused to apply some design thing and say, is this a good process at the moment before we start putting all apps and new digital layers on it? So a lot of what we've got here at the moment across healthcare in any sector is a bunch of sticking plasters and makes it look good for about 5 minutes. But it's not actually, if you were to go back and say, how should this process work before you digitize it? And on top of that, back to your actual question, it's ultimately about optimal allocation of resource. So we have finite resources even when it comes to compute in the world of AI and limited data, etc. So it's really actually about the framework that governs the way resources are allocated. And that's quite a big ask. It's not going to be an overnight fix. But again, people need to start having that broader conversation both at national and local level.
Just short comments, please, because we're running out of time now.
Okay, yeah, you know I can't be trusted. Fundamentally, it is about power, and I'm going to sort of just say, and it's about capitalism and the scaling of decision making. In so many cases, when we are digitizing poor processes, in fact, that's about people trying to center decision-making control and so make decisions scalable and thus take power away from people on the front line. I mean, that's what happens when you have things like startups like, say, Instagram, where you can have 8 people who can control the experiences within, obviously, a small frame for millions, if not billions of people. We, as a society, because of this shaping of what is an important and powerful decision and what we all look up to, think that decisions made on the front line about one person's care or one person's enjoyment of one day don't matter. Whereas, in fact, they do. We need to start trusting people. We need to start investing in the staff that we have and reframing our entire approach to digital and to AI and to sort of as a support mechanism for human decision making. But this goes the whole way through our society. I mean, at the moment, you see in education that with more and more digitization of education, you end up teaching people to think like machines. You're teaching people to think in ways that computers can understand and can mark. And I could talk about that. I can give lectures on that, but I won't. Exactly as you say, we need to be aware of what we're good at and to protect that and to invest in that, because that's what a good life is. And a single decision that helps one person in their home, even if that person is going to die soon and will never tell anyone about whether that day was more dignified or they were humiliated or they were left in pain, that decision matters. And we need to start considering that and empowering that as a country.
Harry, I'm more optimistic, I think, than you are. We've done some research on organisations that are using and implementing AI. It's on our website if you want to look at the detail. But the headline is, those organisations using AI, their staff are more fulfilled, are doing more complicated and more engaging, more challenging jobs, and doing less of the mundane, repetitive jobs. So those workforces where organisations are using AI, on the whole, tend to be happier, more motivated workforces. There's tons of detail behind that. Go and have a look at it. Hence why I'm a bit more optimistic.
Excellent. So thank you very much to our panel. Just grab them on the way out if you have further questions. And I'm just going to hand over to Eleonora. Can we give them a round of applause, please?
Very good. So I will keep the closing remarks quite short, as we covered quite a lot of themes today. We started by looking at mistakes in digital healthcare and why it potentially maybe hasn't fully delivered on its promises, and what we actually concluded was that we're still on the journey. We then spoke about putting patients at the center of care and really not leaving people behind in the design of healthcare technologies, and making sure that really patients are involved because they know best what it is that they need, as Liz and Charlene reminded us today. We also then covered the very thorny topic of trying to deliver high-value partnerships between the public and private sector in the area of health tech, and planted the idea of potentially having a sovereign health fund, although there were some discussions as to the potential of being able to do that. And we then finished off this session today looking at the future of digital healthcare, and I think there were some common agreements there that we really need to understand what outcomes we want to achieve as a society and as a system, and then incentivize healthcare to be able to deliver those. We really need to be thinking about long-term solutions and not just short-term plans that might allow, to fit within sort of certain budget constraints, but in the long run might end up costing more money. And again, if we really want to deliver a good health system for the future, we need to be thinking a lot about public health. So I think that was a quite brief summary of what we've covered today. So thank you so much all for attending. Thank you so much for our speakers. Reform will be continuing to do quite a lot of work in this area. In the more immediate future, we will be doing some work around the spending review. So if you do want to engage with us on that, please contact the Reform team members, there's myself as well, but there's some people sort of at the back and sitting on the sides. Thanks again to our sponsors, obviously, for being able to support us and deliver this conference today. So thanks again to Baxter, PA Consulting, Taurus, and Dr. Link. Thank you so much also for the Reform team for making all of this possible, sending all of the invites and organizing, coordinating the slides and everything. There's really a lot of work that goes behind this, so thank you so much to them. And thank you all again for coming and being here. Thank you so much.